So today class is also very boring class, very factual class on testicular tumors. Yes, right. Yesterday's match was amazing. Uh, I mean, what a win, यार, what a win finally. जैसे बोलते हैं ना कि ऐसे डेथ में से निकल के बाहर आए हैं. So very amazing match yesterday's, and I'm sure all of your spirits are high. All of India's spirits are high, in fact. चलो ग्रेट यू हैड फन पार्टी करने का तो टाइम ही था यार ओकेजन ही ऐसी थी आई डिडंट पार्टी बिकॉज आई वाज प्रीटी ऑक्यूपाइड एंड it's great that you had fun. India won a world cup after such a long time यार 2011 में आखिरी बार वर्ल्ड कप जीता था हमने. चलो बढ़िया है. चलो स्टार्ट करते हैं फिर. we'll also try to finish it by 9. थोड़ा स्टार्ट हो गया बट आई ट्राई टू फिनिश ऑन टाइम. ठीक है. वेरी बोरिंग टॉपिक है आज का भी. वेरी बोरिंग टॉपिक. नथिंग मच टू अंडरस्टैंड. ओनली रट्टा रट्टा रट्टा. ठीक है. तो टेस्टिकुलर ट्यूमर्स, we know that it is relatively uncommon tumor. However, it is one of the commonest malignancy that occurs in males between 20 to 40 years of age. Okay, now age is being an important discriminator because this is one tumor which affects the young. Okay, people in the age group of you and me, such people, such young males are affected, and it is broadly categorized into germ cell tumors and non-germ cell primary tumors. Right, so germ cells we know arise from spermatogenic cells, and majority of germ cell tumors are malignant, whereas non-germ cell primary cells tumors arise from Sertoli cells or Leydig cells. So, and most of non-germ primary tumors are malignant in 10% of cases. Now, non-primary tumors can also be seen in testis, for example, lymphoma, leukemia, and metastasis, and they can present as a testicular mass. So if you were to classify testicular tumors, so you can take a screenshot of this maybe for your quick reference, and we divide them into germ cell tumor, amongst which seminoma is the most common type, okay? And followed by mixed germ cell tumor. So seminoma followed by mixed germ cell tumor, and then we have sex cord stromal tumors and miscellaneous tumors like this. So what are the risk factors? So positive associations are well established with cryptorchidism, prior testicular tumor, in which there is 20 times more risk of being malignancy. So in cryptorchidism, there is 40 times uh, 40 times more risk of testicular carcinoma than a normal intra-abdominal location. Okay, now positive family history, 6 times infertility, intersex syndromes, these are risk factors. Now others, I told you one yesterday, microlithiasis is associated with testicular carcinoma and one of the risk factors as well. Now why are we reading about this? What is our role? So our primary role is to identify tumors at the patient's presentation, accurately stage them, and detect the recurrence during imaging surveillance. Now, regarding staging, yesterday I told you that this tunica albuginea, which is like a tough coat which surrounds the testis, that appears as an echogenic line on the ultrasound. And that is very, very important for us as far as radiologists are concerned, because breach of tunica albuginea changes the stage of the disease. And as we will read subsequently. So if we were to see the normal testis, first of all, ultrasound is the primary modality for investigating testicular lesions because testis is a superficial structure. So high frequency ultrasound, you will see that testis has a homogeneous ecotexture. So homogeneous ecotexture with this granular sort of appearance. This is the normal appearance. Now sometimes testis septae, fine septae are present, which appears as these hypoechoic bands. This is a normal presentation. This is a normal appearance again. And this echogenic line in the center, this is nothing but our mediastinum testis. This is also a normal appearance of mediastinum testis through which all the vessels and the rete testis comes out. So multiple lesions can be seen on ultrasound. So a testicular lesion can be inflammatory, can be associated with syndromes, benign conditions which we read yesterday, and tumors which we'll read today. So inflammatory lesions appear as inflammatory lesions appear on ultrasound as multiple hypoechoic intratesticular masses. So a golden rule, if whenever it is an inflammatory lesion or a benign lesion, is that such lesions will not cause any mass effect. Okay, this is one important factor which helps us differentiating them from malignant lesions. So syndromic associations are seen in Cowden's disease. So for example, and other inflammatory conditions that we see are testicular lipomatosis. So this is how testicular lipomatosis appears. So multiple hyperechoic lesions within the testis with no posterior acoustic shadowing. Now, in congenital adrenal hyperplasia, you can get testicular adrenal rest. So, in an infant with a known CAH, you get a testicular swelling, you do an ultrasound and see this hypoechoic lesion. One of the differentials you'll keep is an congenital adrenal uh, testicular adrenal cell rest. Now, in epidermoid cysts can mimic testicular malignancies, and they appear as these well-defined hypoechoic lesions having this onion ring configuration. So this can come as a spotter. This is testicular epidermoid cyst. Now, what is the role of contrast enhanced ultrasound and elastography? So mainly helps to see whether it is a malignant lesion or a benign lesion or a hematoma. So hematoma, cysts, these will not enhance. Malignant lesions will show washout. Similarly, sonoelastography is used to depict stiffness of a particular tumor. So tumorous lesions are typically more stiff, more elastic, whereas non-tumorous demonstrate soft elasticity. Now, as far as MR is concerned, how does the testis normally appear on MRI? So they are hypo-intense on T1 and they are hyper-intense on T2. So primary modality for imaging testis will remain as T2 weighted image. Now on T2 weighted image, testis appear as bright, and this T2 weighted images allow excellent depiction of any focal solid testicular mass. Okay, so remember all testicular solid masses are hypo intense to normal testis. Normal testis has high signal intensity. Now, what about tunica albuginea? How do we see it on MRI? So tunica albuginea appears as this hypoechoic line. See this hypoechoic line on both T1 and T2. See this hypo-intense line. This is my tunica albuginea. And this is my mediastinum testis again, which is appearing hypo-intense on both T1 and T2. Now, epididymis is assessed predominantly on T2 weighted image, in which is very well separately seen as less hyperintense than testis. So this is my epididymis. So T1 images are useful for evaluation of fat, methemoglobin, both of which have a high signal intensity, right? Contrast material, contrast images are obviously T1 post contrast, and such enhanced images demonstrate heterogeneous enhancement of the testis. So normal testis and epididymis enhance on administration of contrast. Now it can be heterogeneously in signal intensity in the presence of calcifications, necrosis, or hemorrhage. Now, predominant imaging modality for evaluating a testicular lesion is ultrasound and clinical examination. So as a thumb rule, any hard testicular mass is considered a tumor and a malignant tumor for that matter, unless proven otherwise. So you will not see a lot of MR imaging being done for testicular masses, because the management of testicular masses is for any hard palpable mass, you get an ultrasound done. If it is not a hematoma per se, you do an orchidectomy, unilateral orchidectomy, and send it for histopath. So the diagnosis of testicular tumor is made on histopathology, not on imaging. As a role, our role is mainly for staging, and hence in practice, in private, in your residency, you will see that the patients of testicular carcinoma that come to you are mainly for intra-abdominal staging, for the lymph nodal metastasis. Where has it occurred? Distant metastasis. That is why CT scan of chest and abdomen is done, not for primary testicular malignancy. If there is any indeterminate scrotal masses, for that evaluation, a contrast enhanced MR is to be done. So what is the appearance of various tumors on MRI? So seminoma are homogeneously signal intense, homogeneously hypo intense on MRI. whereas mixed GCT will be heterogeneous signal intensity. Teratomas will have macroscopic fat, so they'll show loss of signal on fat suppressed sections, and hematoma will show intrinsic high T1 value. Now, malignant lesions will show washout on contrast administration, whereas benign lesions will show buildup of contrast and plateau of contrast. No washout of contrast will be seen in benign lesions.